So at this point, I'd like to turn things over to Amanda Harvan to begin the didactic portion of the echo. It's all yours, Amanda.
Okay, can you guys hear me okay? All right, so we're going to talk about falls in older adults. So like Margie said, I've been with Summa in the geriatrics group for 12 years today. Actually, today is my work anniversary, and doing a variety of different stuff. But I think it was maybe 6 years ago, 5-6 years ago, Sue Hazlett came to me with wanting to work on this grant project about falls. Okay, we see a lot of older adults with falls, but that really kind of set me on this course to learn as much as I could about falls. And we worked on developing this interdisciplinary falls clinic, which we housed here at our outpatient geriatric center for senior health. And it was a really great experience working in that interdisciplinary team and seeing patients, and being able to focus very specifically on their fall risk factors. So we're going to talk a little bit today about why falls are important, fall screening and assessment, and fall interventions. Okay, so here's our objectives. So why do we care about falls in older adults? They are really common. 36 million falls per year in the US. Those that are more likely to fall are women, those over the age of 85, and minorities as well. Falls are cause injury. Not all falls do, but 8 million of those 36 million a year have injury associated with them. And they really contribute to mortality as well. Falls are the leading cause of injury death in older adults, and accidents are the third leading cause of death in older adults. So it is a common problem. And so that's bad for patients, but it also really increases the fear of falling. So when a patient falls, then they change their behavior because of that fear of falling. And then they're maybe less likely to go out of the house or go to social activities or go to church, and then they get weaker, develop increased risk of depression, and which is this cycle that then increases the risk of falls again. And they're really, falls are a strong predictor of nursing home placement and use of nursing services. So falls are costly to patients. Falls are costly to the healthcare system as well. So over $50 billion annually is spent on falls. They certainly increase nursing home services, but also home care services and inpatient service utilization also. And in addition to being costly for healthcare systems and then taxpayers, they're also really costly to families and unpaid caregivers. And the loss of family income for people staying home to take care of their loved ones is big. And that caregiver stress is a big contributor to difficulty with taking care of our older folks at home. And as much as this is a problem now, as the number of older adults increases, so will the number of falls and the cost associated with these falls. So just a little bit about why do older adults fall? So first of all, there are physiologic changes of aging. Now, falling is not a normal or expected outcome of aging, but some of these physiologic changes really increase people's risk of falling. So as we age, we all lose muscle mass. Even if we're doing our best to stay active, there is still a loss of muscle mass and a loss of tissue flexibility that occurs with aging. There is neuron loss in the brain. That is a fact of aging as well. Dementia is not a normal part of aging, but that certain amount of neuron loss is. And then there's decrease in nerve conduction speed, which can certainly affect people's reaction time and their ability to kind of compensate when they get out of whack. There are changes to vision that occur with aging, specifically increased sensitivity to glare, more difficulty with contrast, more difficulty with night vision, and that certainly sets people up for a risk of falls. And then hearing loss. I thought this was really interesting when I learned about this, because you think like vision makes sense. If you can't see where you're going, how that might increase your risk of falls. But hearing loss has also been associated with fall risk. And we think why that is because we're kind of like bats. Part of how we navigate through our environment is hearing how sound bounces off of stuff. And when we don't have that sensory input of sound in our environment, it actually decreases our awareness of where we are and our ability to navigate through. And then decreased lung capacity is a normal part of aging that affects our reserve, our ability to endure physical activity there. So older adults also have an increased risk of comorbid conditions that can affect fall risk. Certainly osteoarthritis contributes to fall risk. You know, those folks that say, oh, I'm walking, but my knee, I got a trick knee, it gives out on me, or they, you know, have terrible pain in their hip or pain in their back that contributes to their ability to walk. COPD increases as people age, which certainly affects that lung capacity more, and then cardiac problems. And that, you know, contributes in a number of ways, both in, do they have congestive heart failure that might be contributing to respiratory issues and endurance issues, or coronary artery disease, where maybe they have some chest pain if they exert themselves, or arrhythmias that can contribute to people having syncope or blacking out. And then the third thing that increases fall risk that makes older adults more susceptible is the higher number of medications they use. So the more medications that we add on, the more potential there are for side effects that can increase risk of falls. So all of this leads to older adults being higher risk for falls and higher risk for injury related to falls. So in terms of screening people for falls, the American Geriatric Society has guidelines about fall prevention in older adults, and they're really very comprehensive. They recommend looking at a variety of different components for a fall assessment. So they recommend a focus history where you get very specific information about when did you fall, what was going on at the time, did you take your medicine beforehand, did you take your medicine, you know, had you not taken your medicine, kind of were you feeling dizzy or lightheaded, very focused history on the fall experience. A physical exam, looking for any physical components that might contribute to fall risk. Certainly a good medication history. A psychosocial assessment about their living situation, depression, cognition. An environmental assessment, you know, where are they living? What, you know, what's the environment like there? What kind of obstacles might be involved? And then a functional assessment. What are they able to do on their own? But I found that the AGS guidelines very comprehensive and a little bit harder to operationalize. So I really like this Steadi or Steadi that came out of the CDC in looking at stopping elderly accidents, deaths, and injuries. They have really good resources on their website there, both for clinicians, but also for patients, for caregivers, for pharmacists. They have a lot of really interesting things there that can be helpful in reducing fall risk. So this Steadi program recommends screening, assessment, and intervention for everybody over age 65 that lives in the community. So they recommend screening all of those folks with 3 key questions. 1, do you feel unsteady when walking or standing? 2, do you worry about falling? 3, have you fallen in the past year? And if they answer yes to any of those, then they're considered at risk. And I think this is one of those things that's really important to bring up with all of our patients. People don't see their falls as a problem necessarily until it becomes a problem. You know, people will say, oh, I've had some minor falls, some little falls. You don't care about it until it's the one that, you know, where you break your hip or the one that's a significantly life-changing event. So asking folks about them, making our older adults aware that you know, this is a problem helps us move forward with trying to reduce the number of falls. All right, so anybody that's positive in that fall screen should get a further assessment. And these are the components of the Steadi assessment. So you can see how, these are a lot of kind of parts of that AGS assessment, but a little bit more specific there. So we want to look at gait, strength, and balance in our folks to see, how are they walking? And a lot of times you can look at somebody walking and look at their fall risk right there. Some folks I've seen in the clinic, I think, oh my gosh, how do you not fall down all the time? Particularly, I would say it's important when you're evaluating that to have people do a turn, because a lot of times people are doing just fine going straight down the hallway, but then when you ask them to turn around, that's where they have that loss of balance and they get kind of out of whack. We certainly want to look for medications that increase fall risk, and we'll talk a little bit about that in a moment. And then assess for any home hazards. Are there rugs? Are there grab bars? Is there appropriate lighting? Is there a big giant dog that runs underfoot? Are there oxygen tubing throughout the house? Are there steps? Are they in good condition? Things like that. We want to measure orthostatic blood pressure. So that's going to be ideally a lying blood pressure and heart rate, a sitting blood pressure and heart rate, and a standing blood pressure and heart rate. Though oftentimes, it's practical to forego the lying one. People generally don't fall when they're going from sitting or from lying to sitting. It tends to be more sitting to standing. We want to look at visual acuity to determine if there's vision issues that are part of why the patient is having falls. We want to look at folks' feet and talk about their footwear. Maybe those high heels were a good idea 20 years ago, but maybe not so much now. Or oftentimes I'll see patients in the clinic and I always ask to look at the bottom of people's shoes, and you can see they wore all the tread off. I think you're starting to get some new shoes here that might help you grip a little bit better. We should be assessing for vitamin D deficiency, checking vitamin D levels, and then identifying any comorbidities that might be contributing to fall risk, like that COPD, arthritis, congestive heart failure. So a word about medication. It's beyond the scope of our talk today to go through all of the medications that increase fall risk, but I did want to talk a little bit about some classes of medication to be on the lookout for. So certainly anticholinergics are well known for increasing fall risk, risk of dizziness, confusion, vision changes. Anticonvulsants, so things we use for seizure disorder, as well as sometimes neuropathic pain. Antidepressants, and really for all of these medications, it's not necessarily a class effect. There are good and less good medications in these different categories. So, for antidepressants, there are certainly ones that are safer than others. Same thing with medicines for diabetes. If you're taking too much or medications that are causing you to have low blood sugar, that certainly increases your risk for falls. Antihistamines, we probably all know about how Benadryl increases fall risk, or Tylenol PM, that diphenhydramine that's in a lot of those over-the-counter things. Antihypertensives that can drop blood pressure too low or really increase risk of orthostasis. Same with antipsychotics that can cause orthostatic hypotension. The antispasmodics are pretty anticholinergic as well. Benzodiazepines have a known association with fall risk. Same with muscle relaxants. Opioids, again, can increase sedation and risk of falls there. And then the sedative hypnotics, that's the prescription sleep medications, the Z meds like Zolpidem or brand name Ambien. So lots of things to be on the lookout for that may be contributing to that patient's fall risk. Okay, so after you've done your screening and your assessment, then the third component of the Steadi initiative is to intervene. So for everybody, regardless of whether they screen positive for fall risk or not, we want to educate them that falls can be prevented, that it's not a normal part of aging. We want to really empower our patients to talk to their healthcare providers about falls. People are afraid that if their family knows they're falling or the doctor knows they're falling, they're going to make them go in the nursing home and their independence is going to be taken away. So many folks are afraid to talk about it. They'll deny it. So encouraging folks that, hey, if you're having falls, there are things we can do to help. So help us to know about them so we can help you, be as healthy and as independent as you can be, but also to be safe. Should be looking at vitamin D in all of our folks. Referring everybody for community exercise programs or fall prevention programs. We don't have to wait for somebody to have fallen before educating them about the benefits of physical activity and working on balance. We should encourage home modifications like grab bars and handrails and good lighting, being proactive about those to make changes in the home environment to improve safety there. And then reevaluate yearly or after any fall, kind of repeating that screening process there. So for those patients that screen at risk, their screen is positive, we want to address all those individual risk factors and then follow up in 30 to 90 days. So for almost everybody that we encounter, falling is multifactorial. It's almost never just one thing. It's kind of that analogy we use in healthcare about the holes in the Swiss cheese lining up that cause people to fall. So it's really important that we look at what are all of the different risk factors here and address as many of them as we can, because there's certainly going to be some that aren't fixable necessarily. Somebody who's had a leg amputation, or they have severe arthritis and they're not able to, they're not a candidate for surgery or something like that, or they've got major vision issues. But if if vision is one of 8 fall risk factors and we can address the other 7, then we're going to decrease fall risk. So based on what risk factors you identify, that's going to determine the interventions that we do. So if you find somebody with some serious weakness or range of motion limitations, balance impairment, certainly getting physical therapy involved at home or as an outpatient can be really beneficial. There are experts in terms of determining both the home exercise plan, but also what's the most appropriate assistive device. Are they better off with a cane or a walker, or are they better off, on their own? And then we can refer folks for evidence-based exercise programs such as Tai Chi or Matter of Balance to help get people on a good regimen to help improve their balance. If they have footwear problems, we want to educate people about what's proper footwear. I've seen all kinds of crazy things. I had a lady that her slippers, she wore those kind of slip-on slippers and her foot would be edematous and she couldn't fit it in. So she literally used rubber bands to keep her keep her slippers on her feet. Or we had another lady that comes in to the clinic with her shoes untied. And, we asked, well, why don't, do you know your shoes are untied? And it turns out her son, she was living with her son and she couldn't because of arthritis in her hands, she couldn't tie her shoes. So her son was tying her shoes for her. And then something happened and her son ended up in prison or in jail. And so he wasn't there anymore to tie her shoes. So this poor lady's walking around with untied shoes. So our nurse case manager was able to get her those little curly Q shoelace thingies so that she could have her shoes tight without having to tie them. Referring people for diabetic footwear if necessary, podiatry evaluation. Those are relatively easy ways to kind of help people make sure they're on good footing there, so to speak. All right, if there's sensory deficits identified, referring folks to ophthalmology or audiology. We know there's good data that getting your cataracts removed reduces your fall risk. And like I mentioned before, treating hearing loss, getting hearing aids in place also reduces fall risk. If there's nutritional deficits, referring folks to a dietitian or getting them hooked up with the home delivered meal options or started on supplements can be helpful. If they have poorly controlled comorbid conditions, getting them back into their PCP or other specialists to help try to optimize their control of those conditions. If they have positive orthostatic vital signs, we want to certainly address medication as able. And depending on your role, that's going to affect what you're able to do there. I would say, as a caveat, for all of those medicines we looked at, for the most part, those are things that we don't want to stop cold turkey because we're going to put folks at increased risk of developing withdrawal. So it's important to work with the primary care provider and pharmacy to make sure that we're reducing medications in a thoughtful way that's not going to put the patient at increased risk of harm. From a non-pharmacologic standpoint, there's a lot we can do about orthostatic orthostasis, orthostatic hypotension there. Ensuring people are staying hydrated throughout the day. You know, we have folks that say, oh, well, I have to get up and rush to the bathroom, so I try not to drink anything, so I don't pee or leak urine. Getting people doing some regular exercise there while they're sitting. So we talk a lot about ankle pumps to try to get the blood circulating there. Slow position changes. I always tell folks, when you're laying in bed and you want to get up and walk across the room, first sit up, count to 10. Hang your feet over the edge of the bed, count to 10. Stand up, count to 10, and then start going and educating them about the need to give time for that blood flow to get back up there to the brain before they start moving. All right. Again, about the medications, we're looking at, what can we do to reduce those medications that might be contributing? And then the other thing here to note is screening for adherence. So sometimes people get into this situation where they're taking their medicine not consistently, and then they go see their primary care provider and, oh, your A1C is high, your diabetes isn't controlled, let's increase your medication. And so then the days they're actually taking their medication, their sugars are going too low, and the days they're not taking the medicine, they're still too high. And that certainly puts people at risk for particularly hypoglycemia or problems with low blood pressure when they're not taking their medication consistently. If there's concerns for depression, we want to refer for counseling, talk about medication options, and then again, work on that patient activation, motivating the patient or encouraging them to be that active participant in their care, to engage with their care providers on, what are their goals, what's important for them. If there's substance abuse, we want to refer folks for substance abuse support, and finding out in your community what's available that's specific to older adults can be really helpful. The needs of an older adult in recovery are going to be different than the needs of a, say, 20-something-year-old that's trying to stay sober. So having a resource for recovery that's specific for older adults is really, really important for getting their buy-in and hopefully increasing their chance of success. If there are environmental concerns, we can refer for occupational therapy for a home safety evaluation, investigate options for home health aides or increased support from family, or other kind of home modification that may be available to improve their safety there at home. So that's a lot of stuff. It's a lot of different kinds of disciplines and different kinds of people involved there. And because of that multifactorial nature of falls, it's really hard to do this as a one-man job or a one-woman job. Doing these comprehensive evaluations is really time-consuming. It takes a lot of time to kind of delve into all those different areas that are really increasing fall risk. So one way to address this is using an interprofessional approach. In this way, you really maximize efficiency and accuracy. I am a pretty good nurse practitioner. I am not the greatest physical therapist, and I'm certainly not the greatest pharmacist. So using that whole team of folks really helps make sure we have a good, comprehensive, but also feasible care plan for the patient. If they come to see me in the office and they say, oh, well, I fell, and I say, all right, here's what you're going to do. I'm going to send you for physical therapy, and I'm going to stop your blood pressure medicine. Well, if they can't get to the physical therapy, if they don't have transportation, it's probably not going to work. Or if they get all their medications prepackaged at home, and I say, okay, we're going to stop the medicine, but nobody goes and takes it out of their packaging, they're going to keep taking it. So it's really important to have kind of lots of different parties involved in terms of maximizing that ability of that care plan to actually work. Okay, so before we move on to the case, any questions about kind of fall risk assessment and interventions? And I would encourage everybody to check out that CDC Steadi website, because I think there's great handouts on there for patients and caregivers, great toolkits and tips for all of us, really.
So Amanda, you're getting a number of good thank yous, and that it was very comprehensive. Before we move on to the case, real quickly, we had two people jump on, if they would, like right around the time you started, if they could introduce themselves. Abby?
Sorry, I'm dealing with 3 screens and having trouble finding my mute button. Hi, everybody. Abby Morgan from Direction Home, Akron, Canton. It's been a while since I've had an opportunity to join these sessions, and so it was on my calendar, and I'm happy to attend. And we love the study resources, but this was kind of a really great practical how to do it and implement. And so thank you, Amanda.
Thanks, Abby. Good to see you. And Nada? Or Nada? Oh, you're muted, but so there's looks like she's not able to get on, but welcome everyone. Okay, Amanda, thank you so much